I want to kind of welcome all the physical therapists. There's some future PTs I know on the call, ATCs, prospective patients, and some any of our other allied health fields to the webinar and our YouTube channel. This will be posted up on our YouTube channel hopefully by later this afternoon. So that's where a lot of people tend to consume this. My name is Ben, as many of you might know, and I'm the founder and CEO of Lake Washington Physical Therapy here in the Seattle area. A couple of quick housekeeping items on the webinar itself, and that is that there is a Q&A tab. If you see that and kind of hover towards the bottom bar of all of your kind of web interface, and we'll do our best to answer those questions either during the webinar, if it looks like an appropriate kind of time, or offline. I'll bug Dr. Shaffer and we'll get some answers as best we can for that. There will be information for both of us at the bottom of the show notes, so both in the Zoom information as well as on the YouTube channel. So in that situation, you'll have our email through some question you have or a patient you'd like to refer to us, or maybe you're a prospective patient, then you can kind of see if it's a good fit for your needs. And kind of a quick background on the webinar itself. It's entitled Industrial Athletes, Weekend Warriors, and Minimally Invasive Spine Surgery, which I think does a really good job of kind of entailing like everything we're going to go through. And longer title, right? But it should encapsulate everything we're going to talk about today. And so kind of basically the background is kind of like in the kind of the faster paced world that we're all living in. We're all kind of industrial athletes, which I totally agree with that term. It's a fun term because we're kind of using our bodies, whether it be behind a computer or doing something a little more active. And then we're also doing our weekend pursuits as weekend warriors and kind of leisure activities. And nothing beats the Pacific Northwest for weekend activities for sure, especially when the weather cooperates. So we'll kind of go over a couple things, understand the spine and common injuries, minimally invasive spine surgery, which is a game changer. And Dr. Shaffer's got a couple of really new things that he's just getting into, and one of the first guys in the region to really be doing this. And then a Q&A session where we have some questions that people have also sent in ahead of time via our emailers and off of Facebook, Instagram, and Threads comments. So anyways, let me introduce Dr. Andre Shaffer. I'm thrilled to introduce him. This is our first time meeting today, which was awesome, but I feel like we have some similar arcs to our pathway. He's a distinguished orthopedic surgeon. His expertise really, correct me if I'm wrong, is kind of spinal, pelvic, and orthopedic conditions. And what in our group, like what he's really known as is he's the guy to go to when you've got spine and possibly hip involved simultaneously. He is the guy. So that's very early in our group's kind of relationship with him, but he already has that reputation. It's like, this looks really complex in two areas. Send him to Dr. Shaffer. He's kind of the way to go. So kind of managing, degenerative changes in the spine, deformity, and also traumatic conditions. And I know with his background in both sports and his previous careers, which he'll probably touch on, he's seen trauma in a lot of different ways. He advocates for conservative care and modalities such as PT and the utilization of minimally invasive spine surgical techniques when it's necessary. So I think our feeling is, and one of the reasons Mark and the team really wanted to have you on is because like it seems like you're a conservative care first, and then when appropriate, we can get into the surgical component when that is necessary. I think one of the most distinguishing things is your journey was not the traditional one, as I know a lot of the physical therapists on the call was not their traditional path. And prior to pursuing a career in healthcare, he worked as a firefighter and a lifeguard and a number of other odd jobs that hopefully you kind of talk about a little bit too, because I think it kind of helps personalize and makes you so relatable to so many of your clients. And then after earning his medical degree from Cornell in New York City, he completed rigorous training in orthopedic surgery at the esteemed Hospital for Special Surgery, and spent some time in Texas, both in Austin and Corpus Christi. And then a university that people might know a little bit about, Harvard, spent some time up at Harvard at the Orthopedic Trauma Initiative in Boston. So that's really just an awesome resume, and you're still super young. So it sounds like the resume of someone who's like 75, like you're winding down. You also spent some time with Dr. Keith Mayo, working on the Hip and Pelvis Center, which is awesome. Hopefully you talk a little bit about that, from the Core Institute in Phoenix, Arizona. Certified by the American Board of Orthopedic Surgery, which is a great distinguished honor. And then anything else you maybe want to add on that I might have missed or butchered?
I'm a father of three.
That's
That's
that's the that's the
that's most of
yeah.
my weekend warring right now. Father of three.
Well, that's funny that you say that too, because I think so many people on the call, that's kind of whether it be kids or grandkids, that's kind of typically their motivation for seeking out PT and or orthopedic specialist, is that they want to, I can't do the stuff I need to do. So that's a lot of our questions later in the webinar will kind of be kind of centered around those kind of questions too. So without further ado, though, I'll let you take the wheel here and
Right. Let me go ahead
share
and
your
share my
screen.
screen. There we go. All right. So, hi, I'm Andre Shaffer. I'm a spine and hip surgeon here at the Orthopedic Specialist of Seattle, which is one of the Proliance groups. And I'll be giving the talk today about minimally invasive spine surgery and sort of what we have to offer for people who use their bodies either for work, recreation, for their daily life, or for any combination of the three. So, who am I? I'm a former lifeguard. I'm a former Seattle firefighter. That's me, under the Blue Arrow. Um, I used to do a lot of weightlifting, a lot of hiking. That's me in Peru with Orlando. Former rugby player. I was a winger, and I'm a surgeon. I'm a spine surgeon who predominantly likes to do minimally invasive spine surgery. So there you can see me there. It was the case from last week where I'm doing spine endoscopy on a young woman who had radiculopathy, which is a very common condition uh, that people have when they're active. I'm also a parent. These are my three kids. The oldest is 6, but he's 97th percentile for height, 83rd, I think, for weight. I have a 3-year-old on the left and a 1-year-old on the right, and they're also heavy. They're squirmy, and they require a lot of care. Like
You
all
got
of
some
them do.
future people ready for the scrum right there.
Yeah, it feels like a scrum dealing with them. So who is this talk for, right? So I kind of talk about industrial athletes, weekend warriors, and I think parents kind of are the both or both, So I asked him, does your job involve lifting or carrying? Does it involve moving heavy objects, pushing or pulling? Does it involve awkward positions? You don't have to be just a firefighter to have that. Maybe your job involves keeping people alive. So firefighters, police officers, line workers, construction, mechanics, nurses, physical therapists, massage therapists, personal trainers. If you move things or use your body for work, um, this definitely applies to you. And some people say, well, I work in accounting and I just sit down, but people still have to lift and carry boxes. They still have to be physically present. Maybe getting to work and carrying a briefcase is something that you have to do, or a backpack. And those folks can have a lot of pain as well from spine conditions. And then also, weekend warriors, right? Um, are you on a first name basis with your physical therapist or your orthopedic surgeon? Do you need to contribute to your health savings account because of what you like to do Friday through Sunday? Um, is full send in your vocabulary, right? This is probably for you, right? We came up with a bunch of other sports that you could do, right? Skiing, soccer, gymnastics, golf, ultimate frisbee, climbing, hiking. Those are all things that people who can suffer these back injuries that need things. And when I was sitting down and kind of writing the talk, and I was talking about, and I was writing up the industrial athletes part, it really did make me think about what parents and grandparents have to do, right? This is a woman who's carrying her child. Her child is a dynamic load that's moving all around. She's carrying multiple bags. She's trying to balance things. Her spine is being loaded in ways that you may not necessarily anticipate, and this is where people get hurt. She's wearing the heels. I mean, she's trying to get to work. She's in a rush. She's probably not paying attention to her biomechanics right now. And this is where you can get hurt. And so why am I here, right? I'm triple fellowship trained. I did as Ben alluded to, I did my trauma fellowship at Harvard, and that was actually where I first became exposed to sort of the idea of minimally invasive spine surgery, right? Use of tubular retractors and endoscopes to treat spinal pathology. One of the things that traumatologists do a lot of, though, is hip hip work, right? Hip replacements, periacetabular osteotomies. You deal with the pelvis, you deal with pelvis fractures. If you're a traumatologist, and that's sort of your niche. And one of the things that I found as I kind of delved further into the hip preservation world was that there's a huge amount of interplay between the hip and the spine. Your hip, your pelvis, is the base for your spine. And I started to realize I needed to understand the spine more in order to really truly understand the hip and vice versa. And I think now I have a pretty good understanding of them, and I understand that they can drive pathology in other places in each other. And that's just for a lot of the physical therapists, that's a really obvious statement, but for some of the surgeons, it's we're kind of still catching up. And really on the top right here, what you see is this endoscope. This is what really kind of inspired me to go back to fellowship and do a spine fellowship, because it was such a difference from what I saw as a resident, and even as a trauma fellow, for what spine surgery could be, right? Spine surgery didn't have to entail a massive, 3, 6, 9 month recovery, right? It didn't have to be something that, really took you off your feet for at least 3 months. It's something that can be ambulatory and can really let you get back to the activities that you need to do and that you love to do sooner. And, one thing that we do know is that, most people, the vast majority of people, do not need, with back pain or with radicular symptoms or, numbness, burning, tingling in their legs, the vast majority of people don't need surgery. But if you do need surgery, having it done at a reasonable time instead of waiting for a year or 2 years because you're afraid of what the recovery means and entails, portends so much better of an outcome for you. If you have weakness and you have a disc herniation, we can get that disc herniation off. You can rehab better. Your gait, you're not going to have compensatory changes in your gait pattern. You're not going to tweak your hip and your knee and your ankle trying to offload one leg. And those are some of the things that we see now with endoscopies. People who are able to get back fast, right? So I've said, what is minimally invasive spine surgery? I said I'm a minimally invasive spine surgeon. There's no accepted definition. So I want to tell you sort of what I envision as minimally invasive spine surgery. So I look at it as a triangle, kind of a triad, right? So it's a combination. These are all different aspects of what goes into a spine surgery, right? Your skin incision, where is it? What does it entail? How many do you make? Your dissection and retraction strategy. So what are you doing? What are you taking off to see? How are you seeing the structures that you need to see? And then the functional changes that your surgery entails, right? What function are you changing? Are you changing any function in the patient, right? I would be remiss to talk about minimally invasive spine surgery without talking about what's truly minimally invasive, which is starting with conservative management. Like I said, the majority of people get better with conservative management. That includes physical therapy, that includes medications, activity modification. Maybe it means injections, corticosteroid injections, or just diagnostic injections, and time, right? The majority of people don't need surgery. But if these things are something that fails, then maybe you do want to consider surgery, right? So what is
I can interject real quick, not to throw you off, but I feel like just so people appreciate the endoscopy, I feel like it's a little bit like I've been practicing for about 25 years, and I feel like it's kind of where arthroscopy was with open incisions for meniscus, back in the late to mid 90s. And now this is kind of like, and you're kind of on the forefront of that. So hopefully people can kind of appreciate this. So this is important stuff in my mind.
Yeah, no, I mean, I agree. I think spine surgery really is at sort of that sea change moment where we're right on the precipice of arthroscopes or open, and that, like you said, that made a huge difference in sports medicine. So I think we're kind of there, sort of sports spine, if you will. So your skin incision, right? Is it a small incision, right? This is an endoscopy incision. It's about 1 centimeter long. Is it a medium-sized incision? Is it large? Are you doing one incision like you see here on this right image on the left? you see one long midline incision, they're going to dissect all of that tissue down. They're going to open the fascia. They're going to pull muscles off of bone. That's going to have a larger footprint than, one where you have maybe two small incisions and you're doing something with small retractors. You're spreading muscle instead of cutting. And that kind of goes into, our dissection and retraction strategy, right? Is it open surgery, right? Open surgery, like I said, requires fascial incisions, muscle stripping, which denervates the muscles, which revitalizes the muscles in terms of their blood flow. So you do have some muscle loss from that. Bone removal, you put retractors on the tissue. Retractors are things that hold the tissue apart, and that pressure on the tissue can devitalize it. And then there's also the issue of lack of humidity with open procedures, right? Your tissues are used to being bathed in water, in an aqueous solution. And when the tissues dry out, it damages that tissue, right? And that's I think part of what happens with some of the infections that you can see. I think that's what happens with some of the pain that you see. It's just tissues that got dried out. So are you talking about open surgery? Is it a mini open surgery? Are you using tubular retractors, or are you using ultra minimally invasive endoscopy to see? And then the functional changes that your surgery is inducing. Are you denervating something to just take the pain away and you're leaving the structure as is so that it can function the way it has been? Are you decompressing a nerve? Are you taking, ligament? Are you taking bone away? Are you decompressing and then doing an arthroplasty so that spinal motion segment still moves? Or are you doing a fusion so that the spinal segment doesn't move anymore, and so that it heals together in one block of bone? All of these things, and honestly, all of these options are reasonable to do, as long as you have the right goals, and as long as you're, I think, trying to minimize what you're doing, that each sort of domain of invasiveness, right? So if you're doing a fusion, but you're using tubular retractors, so you're not cutting and stripping muscle, and you're using two small incisions, I think that qualifies as minimally invasive. If you're using small incisions and you're doing an arthroplasty, I think that qualifies as minimally invasive, because you're not having as much of a functional change as you would with a fusion. I think the goal for me certainly is to try to avoid doing everything maximally invasive, right? I don't want to do a lot of open fusion surgeries where I have all of the muscle stripping and use of the retractors and things like that. Sometimes you have to, sometimes that's required, but that patient's going to react a lot differently than someone where you're able to do an endoscopic discectomy or an endoscopic rhizotomy or medial branch transection.
And I think for some of the audience out there too, Dr. Shaffer, it's surgeons that are wanting to learn and doing the fellowships and learning the new techniques. It plays a part in it as well. So there's a familiarity with some people doing open, maximally invasive surgeries, and it's not to say it's not warranted, but there could be a better option. But for
Right.
a younger surgeon that's done multiple fellowships like yourself, I think this is something where that can make a difference in your surgical selection of who you're seeing.
Absolutely. So, and then there's a kind of a concept that I think a lot of the literature doesn't talk about, which is cumulative disability, right? So this is how you get from my Ballard office to my Wallingford office, right? It takes 10 minutes. This is a nice direct route, easy, arterials the whole way. And to me, this is, you could look at this as one surgical option, right? Here's another way to get to my office. It's a little bit more around the bout, but at the end of the day, you get to the same place. To me, using tubular retractors or endoscopy is the first option, right? It's a little bit more direct. I can see what I have to see, and the patient ultimately gets there, I think, a lot quicker versus this other route. Open surgery, again, I'm not trying to knock open surgery, but I don't think it's always as, I think it's a little bit harder to recover from. And, for patients who are busy and have a lot of things to do with their lives, they have, things to lift and work and family commitments. Having a long drawn out recovery is something that people don't really want as an option. So I think, the cumulative disability aspect is also part of what goes into, deciding if something is actually minimally invasive. So what is a spine endoscope, right? So this is a spine endoscope on the right. It's a tube that has a working channel in the middle, and it has a separate channel for an inflow and a camera and an outflow. And so you can put it in with a small, 1 centimeter incision. You usually use it for procedures that are less invasive on that functional change sort of continuum. So denervation and decompression. And because it's so small, you have minimal fascial and minimal muscle disruption. Also, because it's so small and because you can see, because there's a camera, you have minimal bone removal before you can see the nerve roots or whatever you're trying to decompress. There's also continuous irrigation, which I think that's actually the game changer with endoscopy, similar to arthroscopy, right? So these potions that you see down here are vinegar. And I like to think of surgery induces an inflammatory response. And I like to think of inflammation as vinegar. You would never drink vinegar straight. That would be horrible, right? But if you put fluid into the vinegar and you dilute it, it's a lot more palatable, right? If you have less vinegar per unit volume, you have a lot better you have a lot less of that sort of vinegar and a lot less of that astringent taste. Well, in endoscopy, right, you're still doing surgery, and so you still are inciting an inflammatory reaction, but you have this fluid that's washing that away and diluting that as we go. And so I think the patients at the end of that case are just in so much better of a space in terms of the inflammatory reaction that they have, right? That I think they do better. And that's borne out honestly by a lot of, by my experience and by a lot of the experience that I've had with, with other people who I know who are doing endoscopy around the country. You call these patients and on day 2, they're like, my leg pain is gone. I'm sore. It's not pain. It's not disability. It's soreness, right? These are people who,
This is exactly what we're seeing in clinic too. Like the endoscopy patient, like you said, they know something was done. They know it's uncomfortable. It's not that searing surgical pain that lasts for weeks.
right. It's soreness. And that to me is that's better, right? If you can get back to work in 4 to 6 weeks and you felt good that whole time, what your gait's going to be normalized. There's a lot of the sort of the biomechanical parts that you haven't disrupted by doing your surgery. And then the other game changer for me is you can see the structures extremely well. These are real views from an endoscopy, where you can see nerve roots very clearly, and you know that there's no pressure on. You're done. In a lot of the traditional surgery, you can't actually see the nerve roots. You know where they are, but you can't see them as they're exiting the frame and as they're running through the lateral recesses. And so you don't know. You just, again, you're feeling, oh yeah, that feels right, but you don't know. With endoscopy, you absolutely know that you got everything that you could. And the way I liken it is, why would you access your living room? Why wouldn't you access your living room by opening a door, as opposed to opening a hole in the wall, right? Traditional surgery is this hole in the wall, whereas endoscopy is the door, right? You're going in through a smaller, controlled opening that you can close, and it's a lot easier to recover from. Opening your door is a 10-minute thing, maybe. Taking your wall out is a 1 month thing, right?
Well, also when you take a wall out, as many people know that a remodel, you don't know necessarily what you're going to find when you take the wall apart.
That's accurate for surgery as well. That can be accurate for surgery as well. So what are the drawbacks, right? So the drawbacks to endoscopy is that it is technically demanding. I think if I hadn't done my hip preservation fellowship, which included a lot of hip arthroscopy, I'd have a harder time with doing spine endoscopy. I think you have to be familiar holding a scope in your hands to understand how you do it. The operative time can be longer, right? You're looking at the anatomy from a different view than is typical. And so it takes a little bit longer to make sure that you're seeing everything. You can get the dorsal root ganglion and impinge on that. And that's not that's not something that's uncommon. I've heard some people say that the the incidence or how often a case of a radiculitis can occur can be up to 20%. So that's something. The fluid that you're putting in can go places, and you have to watch how much fluid you're using. And then I think one of the big reasons that a lot of people aren't also using a lot more endoscopy is because the equipment costs are not they are real. But on the pros, right? Less blood loss, shorter hospital stays, less postoperative back pain, and they do have a similar complication profile. So that's a good thing. The other sort of newer thing that I think is minimally invasive is when people have problems with their discs, is using disc arthroplasty devices as opposed to fusions, right? And so, on the top left, you have the Modus 3 spine that's currently being investigated. You have a Nuvasive Simplify, you have a Mobi C. These are cervical disc arthroplasty devices that you use in the neck. This is the ProDisc L, and then this is the InMotion, which is the former Chariday disc. These are disc replacements that you would use in the back. And then this device over on the left, the bottom left, is for facet joint replacements. This is called the Previous Spine Tops device. And these all essentially change the goal of the surgery from fusing painful structures to stop pain to cutting the painful structures out and replacing their function so that they keep motion. And the benefit to that is that you avoid adjacent segment disease. If you stop one area from moving, then you end up having other areas that take up the stress that motion would create. These are excellent for pain control. They don't do as much damage to surrounding soft tissues, I think, as much as fusions can. And we're actually seeing it in the cervical spine. You can have other areas of discs that look arthritic. And if you do a disc replacement in the cervical spine, over time, those other arthritic areas where the discs are damaged start to look better. You start to see osteophytes, resorb. You start to see better motion, better kinematics in these other levels. There are some drawbacks, right? So, by and large, these all require open surgery. Some in the cervical spine data is pretty clear that it is absolutely the go-to as opposed to a fusion, unless you have a contraindication to a fusion. But the lumbar spine is still the lumbar data is still a bit muddled. It can be difficult to revise these. Oftentimes, if you have to revise them, you have to revise them to a fusion. They don't handle shear very well. So some levels just don't do as well with these disc replacements, like L5S1 can be a very high shear environment. So sometimes it doesn't work. And you do need to have healthy facet joints in the back of your spine in order to deal with these. And then access issues is, if you're trying to get to the L5S1 or L45, sometimes you have to have a vascular surgeon help you get there in order to do the surgery safely. So conditions that you might find that an industrial athlete might find, right? So facet pain and arthritis, disc herniation, lumbar radiculopathy. That's where a disc is squirting out the back and it's pushing on a nerve root, and you're feeling that nerve root pain in either the leg or the arm. Spinal stenosis is where the caliber or the canal width is narrowed because either of a disc herniation or because of those facet or because of that facet arthritis. And then degenerative arthritis, I usually talk about that with respect to the discs. If they're flattened and if they're degenerated, sort of how that can become a problem. And the more you've done early on in life, the more you can have one or many of these conditions. And so facet pain or joint arthritis, one of the things we use the endoscope for is we use it to essentially clip the nerves that go to the facet joints. That lets the facet joints keep moving. That takes the pain away. There are other procedures called radiofrequency ablations, which are similar, but in these cases, they use needles. They're not seeing the nerves, and so they're using needles and they're burning tissue somewhat indiscriminately. Again, it's an accepted procedure. It's something that does do a lot of good, but the nerve sheath is never violated, so the nerve can regrow and you can have pain come back. There is data that shows that these facet, these medial branch transections give you better pain relief for longer. So, and it's a minimally invasive procedure. It takes about 20-30 minutes. You're off out and, you know, getting back to your day.
Yeah, it's remarkable. Those are ones that people come back and they're like, wow, I feel so much better. Like in the past with the ablations, it's there's some collateral damage that can happen, and then also, like you said, like sometimes a year and a half, 2 years later, they're like, hey, it's back again. I got same, kind of facet type pain. So
Yeah. And then like I said, the Premia Tops device is a facet joint replacement. Not as well used yet, but it's got 15-year data. And this is for people who have a spondylolisthesis or a slippage of the vertebrae, so some instability where the facets are arthritic and you have some degeneration in the disc, but it's not degeneration of the disc that's to the point where you would want to do a fusion or a disc arthroplasty. Which oftentimes is contraindicated with spondylolisthesis. But Premium Tops device is something that we're, planning on starting to offer here soon. And these are ambulatory cases, get you in and get you out. These do require an open incision. But if you can keep that motion segment going, you bypass a lot of the issues that can happen with with fusions and whatnot. So disc herniations, right? So you can see on the left here, that's what a disc herniation looks like. I tell people that the disc is like a tire, but instead of being on upright, it's on its side, and instead of being filled with air, it's filled with water. What holds the water in is this cloudy substance in the middle that you see here. That's called the nucleus pulposus. The nucleus pulposus has a lot of negatively charged ions, and that's why it's able to retract the water. And when you pound down on it, the water gets pushed out, and then it gets pulled back in by those negatively charged ions. The thing about negatively charged ions is that if they're exposed to blood or if they're exposed to your immune system, they can incite a huge inflammatory reaction. That's one of the reasons that people, when they have disc herniations, have horrible pain in their leg, horrible back pain right away, and it usually goes away as the inflammatory response goes down. Using an endoscope, you can go in and you can pluck. If conservative management hasn't helped, using an endoscope, you can go in, open the door instead of taking the wall off, open the door, take the part of the disc herniation that's unstable out, wash that area out, and now you've both blunted the immune reaction and the immune response, but you've also decompressed the nerve so that you hopefully get rid of those neurologic symptoms that can sometimes happen as well. Most people who wake up after these endoscopic discectomies tell me that their pain is gone. It's gone. It's not better, it's gone.
it's pretty awesome.
So spinal stenosis is another condition, right? Where, like I said, the caliber, you can see here, you have plenty of room for the nerve roots in the middle between the bones in the front, the bones in the back, except for right here, we have this big disc herniation. And one of the things you can do is you can open up the bone above the disc herniation, pluck the disc herniation out, and make space for that. For that thing. You can use an endoscope to do this. Right? There's ways that have been described where you come in percutaneously, you shave a little bit of bone off the top, going one way, you shave a little bit of bone off the top, going the other way, and then you can access the disc and pull that out. And now you have a comfortable patient. And then last is degenerative arthritis, right? So you can see here that the discs up top, they don't look so bad. The discs on the bottom, they need some help. This is something that, a fusion, depending on your age and your activity level, a fusion is not necessarily an unreasonable thing to consider. But maybe you can do a disc replacement and have normal motion. Again, that requires an open incision. But if it gets you back to moving and helps you feel okay, it's not a bad option. And with doing that, you can avoid some of the issues of adjacent segment degeneration. So, and then you can see here, this is the cervical spine. This is in the neck. You can do up to 2 levels where you do disc replacements. These patients do great. So, and then kind of a last sort of plug for the hip. When the best treatment for your spine is treating your hip, right? You can have on the left, you can have this bump in the front that's called femoroacetabular impingement. That can affect how your pelvis is located in space, just trying to avoid banging your femur into your hip, and that can give you back pain. Doesn't usually give you pain that goes down the leg too much, but that can give you back pain. Or if you have bad arthritis in the hip, right? And so maybe you need a hip arthroscopy to repair your labrum and to reshape the bone on the front of your femur if you have femoroacetabular impingement, or maybe you had arthritis like this person on the right does, and you end up with a hip replacement. Those are both reasonable things that can oftentimes help back pain as well. And so that's sort of into what I have. Thank you. My contact information is listed here, Instagram, and I'd be happy to take questions.
All right, perfect. Thanks for that's a great presentation. Kind of, I think, demystified so many of the things that people might see in a brochure or hear about from friends. I've got a series of questions people have sent in to me during the webinar and prior to, so we can kind of work through these.
Mm-hmm.
Dr. Shaffer, what are the most common causes of back pain that you see in your practice?
Yeah, I mean, I think a lot of people have, disc pain, discogenic pain. I think a lot of people have facet mediated pain. That's I think a really underappreciated cause of back pain. And then there's obviously the muscular strain and things like that. But if you're talking about muscle strain and muscle pain comes and goes, right? But I think the facet pain is kind of what stays there, and that makes sense, right? These are small joints that stabilize massive loads. So
yeah, I think the facet's usually the most underappreciated. I think that's when people talk about, I got a slip disc, whether they know it or not. It's usually there's some facet involvement.
Yeah,
and there are some fairly highly vascularized and neurological sensitive areas right there, and
yeah,
by design, like giving you feedback of what's going on in your spine. So
yeah.
how do you know if back pain, we kind of talked about this a little bit, but how would you know if back pain requires surgery or if it can be managed with non-surgical treatments such as injections and PT?
Yeah. So there's really, again, most back pain, most leg pain, radicular pain is something that can be treated with physical therapy and modalities, right? So I'm a huge believer in acupuncture. I don't have problems with people going to chiropractors. In general, I think, conservative management is excellent, right? Massage helps people. Um, where I worry about folks is when they have other symptoms that sort of look like critical instability or that look like neurologic compromise, right? So if you have pathologic reflexes, if you have bowel and bladder incontinence or numbness in the groin, these are things we call alarm symptoms. Those are things that or weakness in the legs that's not getting better pretty quickly. Those are things that I kind of think, you need something sooner than later, and that may get me to be a little bit more aggressive, but pretty much to a person, I'm trying to get people to physical therapy because it works wonders.
And I think those red flag symptoms you're talking about, when with our team, we're about 70-80% people coming to PT first before they get referred out. That's one of the things. If we're not seeing improvement very quickly, that's a referral to Dr. Shaffer or someone similar in your region. So if you're someone out there that's kind of suffering from that would be something to have attention as soon as possible on that. You kind of talked about some of the pros and cons, but what are the potential risks and benefits of surgery for your disc herniation?
Yeah, no, so I think right, obviously anytime you're doing surgery near the nerves, there's a risk of injury to the nerves. You can have wound complications, infections. I think the biggest risk with open surgery is iatrogenic or surgeon caused destabilization of that motion segment that can cause back pain. You can also have dural tears, right? So you can accidentally injure the lining that covers over the spinal cord. You can have a spinal cord fluid leak. And then I think another risk is reherniation, right? So just because I take out that unstable portion of the disc that's loose and free, there's still a hole there, and that hole has to heal. even when that hole heals, it never quite heals with the same structural integrity as sort of the native lining, the native tire does, so to speak. And so you can, if you break off another fragment of that nucleus or that inner portion of the disc, that can push out as well. The rate of that is about 5 to 6%.
A question that one of my neighbors catches me. I walk my dog every day, usually walking or jogging with my dog, and I get stopped by neighbors and have questions asked to me because they know what I do. And that was the question, which I thought you'd be a great person to answer this. So someone who's having kind of radicular or lower back pains, or possibly degenerative disc disease, but also as a candidate for a total hip, what order of operation would you kind of address that, since you're someone who specializes in both?
Yeah. So it depends on what you're going to do. It depends on A, which one is more symptomatic, and then B, what you're planning on doing for the back, actually. If your back is stiff and you're planning on fusing your back, you should do the hip first. And the reason you should do the hip first is because people who have a fused or stiff back that have hip replacements, they have a higher risk of dislocating that hip. And so if you do the hip replacement first and you let that heal, the longer you go between the hip replacement and any spine fusion or any procedure that makes your spine more stiff, the better chance you have of lessening the risk of a dislocation of your hip. If you're gonna do disc arthroplasty, or you're not gonna fuse your spine and your spine is flexible, then it doesn't really matter as much. But generally, the people who are looking at having a total hip have fairly stiff spines, and so I tell them to do their hip first generally.
That's good feedback. I think you talked about this a little bit in the presentation, but maybe just to sum this up one more time, maybe the difference in recovery from traditional open spine surgery versus minimally invasive spine surgery.
Yeah. So
Depends
I think
what you're doing,
yeah,
of course.
right. So I think, if we're talking about a disc herniation, I think most people right after either a surgery feel pretty good with respect to the leg symptoms that they have, right? I think the difference is the back symptoms that you have. Patients who have an open surgery for their back, it just takes longer. You're looking at 6 weeks. Patients who have endoscopy, it's shorter. It takes 2 weeks. And the intensity is less, right? Endoscopy gives you it's soreness as opposed to, wow, I really had surgery.
Yeah, I think we see, like, in the rehab side of things too, that we can really progress the program so much faster with endoscopy. So I think if people have goals of travel or other recreation, I think it'll get them on that road much faster in the rehab too. I guess this would be, you kind of answered this as well, but how long is the recovery process after spine surgery typically, and what can you expect to be doing during that time?
Yeah. So, I mean, recovery means a lot of things to a lot of different people, right? It may mean, I forgot I had back surgery because I feel great. It may mean when do the symptoms that got me in here go away, right? It may mean when can I get up and walk, and so pretty much with everything, you can get up and walk right away, right? We design the surgery, we do the surgeries the way we do to encourage, not just allow, but encourage ambulation right away. I generally tell people to not do any heavy impact activities for 4 to 6 weeks, especially if I'm doing a fusion or something like that. For discectomies, for the endoscopic discectomies, I tell people 2 weeks. I want the incision to heal, and I want to make sure that they're doing okay and they're not having any residual leg pain. There's no real consensus for sort of when you let someone go back to their activities. I have colleagues who say, "Oh, I hold them for 6 weeks." I have colleagues who say, "I let them go at 2 weeks. Incision's healed. Go do your thing." And I think I tend more towards that side. And I think most people at 2 weeks after endoscopy are able to do most of the things that they want to do. I obviously tell people that reherniation risk is real. So it's not like there's no risk. And so I make sure I tell people that. But, if you're someone who's like, look, I want to go climb ladders and do something intense, or hey, I want to go play football because I'm a college athlete and that's like what I do and I'm getting ready for the draft. Well, we have a conversation about what risks you're taking by moving quicker. But I don't think there's any absolutes behind that stuff. Now, all of that said, people, even with endoscopy, people continue to recover and get stronger and get better with more time, right? And so when people ask me this kind of question, the cover question, in a number of different ways, hip replacement, broken bone, et cetera, et cetera. And I think I always bring up football players. I say, you see a football player, they tore their ACL, their job at that point is to rehab. That's all they do. They rehab, they have dietitians, they have an entire staff, and they rehab year round. And they're never as great the next season. They're always better the second season after that. So I tell people that it takes time. It just takes your body time to truly recover from everything. That said, do you want an intense recovery, right? Or do you want a less intense recovery? And I think most people would choose a less intense recovery.
100% agreed. Are there alternative treatments or therapies that I should consider before opting for surgery? How's that checklist in your mind? How do you kind of do that for patients?
Yeah. So, I mean, I think a lot of it depends on sort of how long they've had their symptoms, and what they've done up to date. I don't like telling people the first time, well, you need surgery. I actually really dislike that. And so, we go down the checklist. Have you done physical therapy? Right. Have you tried activity modification? What medications have you used? Are you icing, elevating? Are you exercising? Right. A lot of times people, have this pain and they just sort of freeze up. They don't do anything. And that's kind of what does it. Have you looked at, your biomechanics at work and things like that? And those are things that's where I think some of these being able to refer to physical therapists that you trust really helps. Because they're able to do a lot of that stuff in more depth than I can. So
I guess that's a good follow-up question, because we have a lot of physical therapists that will see this. Is what makes an orthopedic surgeon trust the physical therapist, or what would make you want to refer people to a certain physical therapist over others?
For me, it's having an open lines of communication. For me, it's someone who understands the biomechanics of what they're trying to treat. It's someone who, is listening to their patients. What makes me trust a physical therapist is, a group that, where people are seeing their patients and they're not kind of getting passed between therapists a lot, unless it's, absolutely necessary. A lot of it is patient experience. So
yeah, that's what we hope. That's what we kind of work on too. All right, I got the final set of questions here.
Okay.
So these are going to be a little more fun. But,
yeah.
All right, toughest position in rugby.
Okay, so it's either a hooker or it's the fly half.
Who is the toughest player on the rugby field?
Probably the hooker.
Okay. Your favorite firefighting moment?
Oh man.
There's probably a lot of them, but
oh man, that's a hard question to ask or answer. It would have been either my first fire, my first due fire that we fought, or it would have been my first rescue.
That's awesome. A first rescue would be really monumental.
Yeah, it was pretty cool.
Joe Purdy or Patrick Mahomes?
I gotta go with Mahomes. He's done it before.
Agreed. As a lifeguard, any big saves in the water?
I got one kid that was starting to drown. I got one kid. It was the one I got, but yeah.
Well, maybe a follow-up question on that. How many firefighting and lifeguard life saves have you had? Have you got how many marks on the helmet do you got?
Yeah, no, I had one. I've had one as a lifeguard, and I had 2 rescues as a firefighter.
That's pretty impressive.
For fires, yeah.
For fires. While on your fellowship in Texas, your favorite Austin memory?
My favorite Austin memory. So I actually was in practice in Texas But my favorite Austin memory would probably be delivering my daughter.
Oh, wow.
Yeah.
That's, and then two more Seattle questions here. Your
Mhm.
favorite UW sports moment?
That would be when UW beat USC back when we had Sarkeesian.
Okay, that was a big one.
That was
And
huge.
and then your favorite Seattle athlete all time? Who do you got there?
Ooh, favorite
Oh,
Seattle athlete? Oh man, I
there's a
wasn't
lot.
expecting that. Let's say Sean Kemp.
Ooh, the Rain Man. I like that.
Yeah,
I love.
say Sean
He's
Kemp.
he's probably due for some hip work too. He might be. He might
Probably.
be
Hey Sean, if
no
you see this,
offense,
come see me.
no offense, Sean. Awesome. Hey, well, I really appreciate you doing this. Again, we'll have all the information how to reach out to Dr. Shaffer and how to watch a recording of this, etc. Um, in the notes, and we'll email that out to everybody that attended. Feel free to share that with folks. And anything else you want to close with? Because we really appreciate you showing up for this.
Yeah, no, happy to see whoever needs help. Even if I can't help you, I can at least generally point you in the right direction. And I treat everybody like I try and treat my family. So
Awesome. Well, you're one of our favorites, and we're super excited that you're in the region, and appreciate you doing this. And have a good rest of the week,
yeah,
and take care, everyone.
cool. Thanks for having me.